And I see two people attending, and I'd like to welcome you to our Managed Alcohol Program Study Community of Practice. And this is being recorded and it will be shared with others. So, but I welcome those two who are here live with us. I want to introduce you to Bernie Pauly and Clifton Chow, who are members of the Canadian Managed Alcohol Program Study Research Team. And today they're going to be sharing some research that they've undertaken on the feasibility of cannabis substitution for alcohol and managed alcohol programs. And so I'm going to hand it over to Bernie and Clifton.
Great. Thanks, Josh. And good morning, everyone. Totally recognize that we're in a time of very much unknown, shifting, and need for rapid action around COVID-19. And I think we're all acutely aware that it has potential to dramatically impact populations who are homeless or at risk of homeless. And while we're going to proceed and do, a quick presentation of the findings of our cannabis substitution research, we also are going to ask you at the end if you want us to, if we want to discuss some of the public health approaches and strategies that would be relevant to programs like MAP, and whether or not you would see this as a potential listserv discussion, roundtable, or webinar. So just keeping that in mind. So thanks to those that have joined. I'm going to start off, and then Clifton and I are going to go back and forth a little bit on this. So I think everyone knows that about a year ago, we received funding to look at the feasibility of cannabis substitution in managed alcohol programs. And there were a number of reasons that we actually wanted to do that. And this slide just gives a bit of background, recognizing that while cannabis obviously is not without harms, the scale of harms is less than that for alcohol. And you can look at sort of the harms of alcohol writ large in the population, as well as specifically for the populations we work with, that there's a high rate of harms. And interestingly, cannabis use has been associated with lower use of alcohol and other substances in a number of studies. So in other words, people can and do substitute cannabis for alcohol. And particularly when it comes to people with problematic alcohol use, severe alcohol use disorder, cannabis meets 6 of the 7 criteria for alcohol substitution therapy, but the recommendation internationally is that we need more research specifically on this to look at therapeutic options for MAP participants. So we undertook this feasibility study with 3 objectives to look at the sample characteristics, suitability, and acceptability of cannabis substitution as part of MAP from the perspective of 3 groups: MAP decision makers, clients, managers, and staff. We wanted to look at practical, legal, financial, ethical issues related to cannabis substitution, and to actually develop a draft protocol for conducting a pilot and control trial of implementation of MAP. And I can tell you that we actually have been able to do all 3 of those things. We're going to begin with a couple of findings from the Cannabis Substitution Project. Clifton, am I switching over to you? I think you're switching.
No, not yet.
Not yet. Keep going, Bernie. Okay, Bernie will keep going. So here you see a table of the quantitative findings around marijuana use from phase 1 and 2 of our MAP study. So this was the big study where we took what our MAP participants and controls told us. So you can see There's 185 MAP participants, 200 controls. And you can see here that the lifetime use of marijuana is high in both groups, 87, 91% respectively. Their past 12 months is also high, although you'll notice the MAPS is 54, the controls is 78. So the MAPS are lower, and then a similar pattern in the last 30 days, 43% for the MAPS and 69%. And what this is telling us, you can also see, sorry, I'll just give the last one, that the number of days that the MAP participants used marijuana in the last 30 was 6.94, and for the controls it was 10. So the slightly higher use of cannabis over past 12 months, past 30 days, and number of days is probably related to people getting into MAPS and potentially restrictions on cannabis in managed alcohol programs, as well as, of course.
Oh, I'm such a dunce.
Hello. Welcome. Everybody okay?
Yeah.
Okay, great. It's probably related to people obviously having a regular supply of alcohol, but also potentially restrictions on cannabis once they get into MAPS, i.e. policies that might prohibit other type of drug use and not being having spaces to use other substances. And so this looked at our qualitative findings, and this is what we found.
Why can't I? What's going on?
I think, sir, whoever's chatting right now needs to mute their video. We can all hear you.
You can mute, or if you have a question, let us know, and we will see if we can help you. So this slide highlights what we found in the qualitative findings, that factors impacting use were related to the perception of participants of zero tolerance for cannabis in MAP. People were concerned about losing space, getting evicted or banned if they were found to be using cannabis, and criminalization, i.e. the potential of being arrested. And remember, that was collected prior to legalization.
Hi, Bernie. Sorry to interrupt. Hi, Jim. I think you need to mute your mic. You had it muted, then you unmuted there.
I can still be stressed if I watch it. It's actually really stressed for the first time.
Maybe Josh, I can just jump in. To unmute your mic, just go to the little, or to mute your mic, just go to the little microphone at the bottom and just hit mute. It should be kind of towards the left of your screen.
There's also someone on the phone, so I'm not sure if it's *6, the same as other phones, but that's how you would mute for most phones.
Awesome, thanks, Brittany. So on this slide, what we see is a research approach that we used in the feasibility study. I just showed you findings from the whole MAP study, which it's really just an analysis of data that we had already collected about cannabis use that provides some interesting findings. And then for the cannabis feasibility study that we did over the last year, we used a community-based approach where we co-designed the study with the community organizations who were partners. And thank you to all of the partners that were involved in helping us to design how this study should be done, from questionnaire development to collaboration and data collection. And then Clifton led the analysis on behalf of the research team. We worked together to develop a community report, which was shared with community partners in kind of mid-February, and we worked together to finalize recommendations from the study. So we're just going to tell you a bit about what we found, and then also tell you a bit about what our recommendations are. So data was collected from 6 maps. We did qualitative interviews with leaders, managers and staff, 17 managers and staff, and we did surveys and open-ended questions with 19 MAP clients in, I think, 6 different programs. And we asked them about, we really wanted to know, was cannabis substitution feasible and acceptable? And if it was, how should we go about to do it? And the way we organized the information was we used what's called the Consolidated Framework for Implementation Research, where we looked at individual characteristics, intervention characteristics, process of implementation, inner and outer setting. So here's some of our key recommendations related to the intervention in terms of what kind of model, what type of cannabis, and other considerations, and then also the research design that people suggested would be good for evaluating. So I'm pretty sure I'm turning it over to Clifton
Yeah,
here.
thanks, Bernie. So now I'll just go over some of the key findings from the interviews. So Bernie, next slide. So as Bernie said, we framed our results in terms of those CFIR domains. So I'll start off with some of the characteristics of the clients we spoke to. And as Bernie mentioned, we were able to interview a total of 19 clients from 6 of the programs. And the mean audit score, which measures the risk of alcohol dependence, had a mean of 27.6. So any score that's greater than 13 for women, 15 for men, indicates that a person may be dependent, and scores of 20 or more are indicating that they're likely to be dependent. So some of the common drinking goals that were reported by clients were to eventually achieve either complete abstinence with 41% or 24% reported wanting to drink safer. Next slide, thanks. So in terms of current cannabis use, the majority of participants reported using it daily or almost daily at 53%. Dry smoked cannabis was the preferred method for the vast majority of clients that we interviewed at 68%. We also had clients indicate that they used cannabis to deal with alcohol cravings and withdrawal symptoms. Cannabis was not a new substance to them. They were quite experienced with this particular substance. Next slide. Moving on to the intervention characteristics. We tried to answer 2 main questions. So what was the preference for the type of cannabis amongst the staff and clients? And 2, we asked about preferences in terms of how that cannabis would be administered. So the majority of clients favored dry smoked cannabis. So it was the form that they had consumed previously, so they were most familiar and comfortable with it. Edibles were also highly ranked at 61%, with capsules coming up third at about 50%. We had also asked about vaporizers, and for many clients, they reported that this form of administration would have been a deal breaker for them. But it's important to note that when we conducted these interviews, it was around fall of 2019. So this was the same period when there were a number of media stories covering health concerns around vaping. Sorry, just go one more thing on the previous slide, Bernie, thanks. When we posed the same question to staff, they also acknowledged that dry smoked cannabis was one of the top preferences due to comfort that their clients and themselves had with the familiarity of that form. Though there was a recognition that administering dry smoked cannabis was more difficult than edibles or capsules, as it potentially requires the staff to do the rollings. So unless pre-rolled joints could be obtained for administration, that could have been a potential issue. Smoked cannabis was also noted to have a challenge where it's required to be consumed outside the premises. So that could introduce a high possibility of sharing amongst clients, which would be sort of alleviated if it was a edible or a capsule, which could be taken sort of in front of the administering staff. Next slide, Brittany. So in terms of how the cannabis would be administered, we originally presented a number of ways that could be structured, from partial substitution of cannabis for alcohol to models where we are completely replacing the alcohol with cannabis after a transition period. The overall preference from both staff and clients was for a partial substitution model, where only a number of the regular daily alcohol doses are replaced with cannabis. So amongst the partial substitution models that we presented to them, we gave them 3 different variations on what that could look like. One was where it was where at designated administration times, the alcohol is replaced with cannabis. The second is where at those designated administration times, the client is given the choice of whether to receive alcohol or cannabis. And the third variation of that is where clients would receive reduced doses of alcohol, daily doses of alcohol, while the cannabis is provided to them at the start of the day, and they self-administer as they need. So the variation where clients are given the choice at those designated administration times was preferred by most and noted to be a more client-centered in its approach. So while participants are commonly ranked, some participants commonly ranked the self-administration highly in terms of a preference, only about 58% of them were willing to participate in a version where it was self-managed. With several, they refused this option due to concerns about self-management, about sharing, about co-intoxication in the program. Next slide. So some of the concerns that impact the intervention characteristics brought up by the people that we interviewed were, as I touched on briefly, the sharing of cannabis. So staff and clients themselves voice that selling or stockpiling the program dispensed cannabis could be a problem, so using it for trading and so forth. So the sharing aspect was also brought up by clients, as that is what the current culture is like. So if they see their friends dealing with withdrawal currently from alcohol, right now they will share what they have with them. That's a way of looking out for each other to help support each other in that way. So when they see someone in need and going through withdrawal, they will currently share whatever alcohol they have with that person to help them out. So the issue of sharing is exacerbated when the form of cannabis is dry smoked cannabis. So the reason being is that it needs to be smoked outdoors and away from the view of those administering it. So this could create situations where sharing is more likely. So one of the ways to mitigate this issue could be the use of cannabis and, the use of edibles and capsules instead. So these forms were still within the client's top 3 choices with edibles and capsules. These could be consumed in front of the administering staff right after being dispensed. So another concern are smoking bylaws. As mentioned, people need to consume dry cannabis outdoors. And this creates safety concerns when it gets, for example, really cold outside during the winter months. So having to send clients into the cold to consume their doses isn't the most ideal situation, especially in parts of Canada where the colder climates in the winter. So edibles could be another way that could be addressing this issue. Next slide. So in terms of process of implementation, some of the issues that were identified by participants was funding. So current funding is very limited. For many sites, it comes from client contributions, program budget allocations, as well as fundraising and private donations. So the ability to incorporate a new substance into this budget and funding framework is quite a challenge. So there is the potential to, when we talk to some of the managers and staff, there is some potential to reallocate a portion of the alcohol funds to cannabis, depending on the amount of alcohol that is replaced by the cannabis, as well as the relative cost of cannabis compared to the alcohol. So some sites were also willing to submit their own funding applications, and also some sites did have staff currently there that do grant writing. So along with the research team, there is some capacity to submit a grant that could allow for funds to be transferred directly to sites, which would also alleviate some concerns around the transferring of funds. Next slide. So staffing, that was another major issue that was brought up by some of the sites. Some of them lack regular clinical support or clinic hours. There is physician availability for clients at each of the sites, though it may be at external community clinics. So there is a definitely inconsistent nursing between the sites, as evident by the concerns about the limited clinic hours on site and access to on-site clinicians. And in fact, administration of alcohol at some sites is currently done by non-clinical staff. And in terms of implementing a cannabis intervention, general training for staff about cannabis and cannabis best practices was requested by the staff as a potential resource that could be provided by the research team. So that next slide, that'll bring us into what they sort of requested. So in terms of the staff and managers, they were looking for protocols and assessment tools to be provided by the research team. Staff reported having adequate storage space, but needed appropriate materials to really utilize that space for cannabis storage. For example, needing equipment such as lock boxes and weighing scales for administration, things like that. There was concerns touched on earlier about spaces for consumption of smoked cannabis. So depending on if the form is a smoked form or an edible form, those concerns, they stem from those bylaw regulations that I spoke of earlier about smoking and even vaping, which has to be done outdoors. So this ties into the potential concerns about sharing of program provided cannabis, because people that would be required to smoke and consume outside, which is away from the view of the administrating staff, that concern about sharing is quite, was voiced by many participants. In terms of what clients were hoping could be provided as resources, they were looking for perhaps some enhanced supports through either peers, through staff, or through family members, including some counseling supports that they voiced to help make that transition from alcohol to cannabis. Next slide. So moving on to the inner settings of the programs, we're looking at buy-in for the idea of cannabis substitution. So 6 of the 7 sites that we connected with did express support in principle for cannabis substitution and moving forward with that. 60% expressed clear support, while others felt further consultation, such as a needs assessment would be needed to be done with participants. So despite most leaders expressing support in principle, some of the managers and frontline staff were unsure of how much that would translate into structural support at the program level. So for many sites, this is still a fairly new idea due to marijuana being recently legalized, in addition to the uncertainty regarding funding of such an endeavor. Next slide. So in terms of outer setting, we're looking at approvals and what kind of approvals would be necessary to move forward with this. So beyond ethical approvals required from universities, staff and organizational leads did mention approvals from municipalities. So getting approvals from, for example, the city is not much different than what was required when we were conducting our previous managed alcohol evaluation. So some sites are within a city jurisdiction, so we had to get approval from them to do those evaluations and accessing of data. And the similar story would be with health agencies, depending on the data that we were attempting to gather. Next slide. So just a quick summary of the feedback from our participants. Clients currently are using cannabis for alcohol, harm reduction, and substitution. The clients expressed interest and need for a formalized program with additional peer and staff supports. And there was a preference for dry cannabis through a partial substitution, where there is a choice during the administration of choosing to receive either alcohol or cannabis. And edibles and capsules may address the sharing concerns or the consumption space concerns, which was brought up because they can be consumed on the spot in front of the person that's administering the dosage. Next slide. And there was support in principle from organizational leads that we connected with from 6 of the 7 sites, but translation into structural supports was uncertain at the staff level. Additional necessary implementation resources vary across the sites, but they generally do include funding for cannabis supply, a space for consumption of the cannabis, storage space, materials to properly secure the substance. And other resources that was brought up was the need for additional clinical staff and additional support, such as an educational component for existing staff. So I'll pass it back to Bernie.
So I'm just going to talk briefly about kind of how would we evaluate this and what did people tell us was a good way to evaluate it, such a program. We basically asked people about 3 different kinds of approaches. We could take sort of what's called a typical clinical trial, and that would be where the research team procures the cannabis, sets up all the protocols, and then evaluates it. The other option was a third-party program evaluation, which is where the community organization procures the cannabis, sets up the protocols, and then our team would evaluate it. And that's pretty much how we've done, the Canadian Managed Alcohol Program study to date. The third is moving to a collaborative approach to research or a hybrid model. And that would be where we would work together community programs would likely procure the cannabis, but then we work together on protocols and evaluation. And I'm just going to briefly touch on each of these now. So the clinical trial means that we, the researchers, would obtain a research license through Health Canada to procure the cannabis. Cannabis becomes then treated as a control substance, and there are a large number of requirements about storage, about incidents that have to be reported, and so on. And so all of that would take place through the research study. As I mentioned, the third-party evaluation is that the MAPS would procure, develop, fund the cannabis intervention, and CMAPS would evaluate the outcomes. The third is the hybrid model. So here, to sort of not make it so overly challenging to procure the cannabis, the MAPS would be responsible for procurement and provision of cannabis. I recognize that puts more responsibility on the MAPS, but it's actually got fewer controls than if it goes through the research study, as well as the volume we could get through the research study could also be in question, and the types. CMAPS would collaborate with MAPS on the program design, and the research team would apply for funding to obtain additional clinical support. So in other words, we'd be applying through research for additional funding for the clinical intervention, as well as to evaluate the outcomes of the intervention. And
I can touch on this
turn it over to Clifton.
Sure. So in terms of the different research designs, in terms of how we might actually evaluate this, we presented 3 different research designs to staff and clients. The first being the most simple, which is an observational study. So basically that would mean that cannabis substitution would start at the site, and we as researchers observe and monitor and would interview participants during that period of time and monitor the effects of that program. So that's the very bare bones, most easiest way we could do it. The second one is a within subject control, where we have a period of observation before and after starting the cannabis substitution. So for example, we do a period of about 3 months of measurements with the clients before they start cannabis substitution. So during that time, we take baseline measurements and follow up with them during that period, recording their current consumption of both alcohol and cannabis, amongst other measures. And then clients would start the cannabis substitution. So the whole group would start at the same time. And we continue to follow those participants up for another few months and continue to collect measurements and interviews. So in that sense, participants are acting as their own controls, where we can compare the pre and post start of cannabis intervention measurements. So that's the second one. The third one is the most scientifically rigorous and most complex design, is the randomized control design. So basically it's similar to the within subject control design, but it's a staggered start type of model. So clients, first of all, are randomized into 2 groups. One group starts the cannabis substitution first, with the second group starting a few months afterwards. So we still have that 3-month period before everyone starts, so that we can gather those baseline measurements. But with this design, it allows us to have both participants acting as their own control, because everyone will have that point of measurement before cannabis started, as well as being able to compare between participants, because there will be a period of time where there are some clients who have started cannabis and some clients who have not started cannabis. So we can control and compare that way as well. So that's the randomized control design. So next slide, Bernie. So the majority of staff and clients preferred the within subject design. So the second variation of that. So the one where we do baseline measurements and then everyone starts simultaneously. The randomized control came in second with staff, though they understood the scientific value of the randomization. They felt it may create problems amongst clients that start first, with those that are randomized to begin a bit later. Clients also did mention things like potential jealousy or disappointment or feeling ripped off if they were randomized into the second group, which would start cannabis a few months later. Sharing may also be exacerbated for people within the site, as those that are receiving cannabis first may share with those that aren't receiving it yet. So that could also impact the results of how that design is set up. So, and this is, like I mentioned, very possible situation that's brought up by clients, you know, in those situations where they see their friends aren't doing well or doing without, they share amongst them. So all these are concerns that are raised by participants about a randomized control design. So now I'll just pass it back to Bernie just to talk about some recommendations.
So in our recommendations, we address 2 things. One is what should the cannabis intervention look like, including the type of model and the type of cannabis provided, and then also the research design to evaluate it. So I'm just going to end with those 2 things. In terms of the cannabis intervention, the one that was recommended through this research and collaborations was the hybrid model, which is where MAP programs would procure the cannabis. We would work together on the protocol, and then we would put in for research funding to cover the costs of the intervention and costs of the evaluation. The partial substitution model, where participants can choose at regular times to have cannabis substituted for alcohol. So having client choice, but staff administration, and dry smoke cannabis or edibles as the preferred type of cannabis. And then, as Clifton just mentioned, the within subjects control. And what that means is we would follow people who are on cannabis and follow them and see what changes happen individual by individual and then the group overall. So those are our findings from this study. And I would welcome any thoughts or reactions you have on any aspect of it, the proposed models, what you think might be important in the clinical support role. You can see there under number 3, some of our ideas would be to focus on substitution goals, safer use education, motivational interviewing, harm reduction education, and then any kind of pros and cons of the way that we come in. So we welcome your responses to that. And if there's other questions that you have that you want to discuss, please feel free to raise those as well. So we are on Zoom, which means we can completely open this up, and you just have to unmute your mic in order to ask a question or make a comment. So we turn it over to you, those that have joined us today.
Thanks, Bernie. That was fantastic. And thank you, Clifton. That was a great presentation. I really appreciated your the detail and the thought you put into today's talk. As Bernie outlined, those with questions, now's an opportunity to ask those. I can perhaps get it started, Bernie. One question I had was, and apologies if I missed this, was about the cannabis and the dosage. And knowing that there's many different varieties and types of cannabis, and you know, the strength of cannabis can vary. How have you thought about that complexity?
We have, Josh, and it is complex because we have been talking with participants about what type of cannabis they use, the type of dosing, because effects are very much different. And we have some, you know, really great advice and direction from the EDGE group, the East Side Illicit Drinkers for Education. We've also talked with some of the people who are running cannabis substitution programs right now in low-income and homeless communities in Victoria and Vancouver. So we have, I should mention, and Clifton can definitely add here anything on dosing, is we are working to sort some of that out in the protocol, and we've actually got a draft protocol, which I would say that section is still needing to be sketched out. So if people on the phone have suggestions around that would be very welcome. Clifton, do you want to add anything in terms of dosing?
So in terms of how we're sort of thinking about it right now, with the hybrid model, we would also be getting funding or attempting to get funding to have a clinician on the site. So the way that this clinician will work with the participants is that they would have weekly meetings with them to sort of decide on what the dosing would be, where they would start off. So how much cannabis, how much alcohol would be replaced by cannabis, and which dosing times. Depending on the participant, there could be variations in how much of a partial substitution that they would want. Some participants may only want very little of their alcohol substituted at the start, while other participants may want to be have more of the alcohol be substituted. So that weekly sort of meeting with the clinician will allow over time the tailoring and the adjusting that would be required to sort of find that balance of how much cannabis would be required to replace the amount of alcohol. And also the source of cannabis, now that it has been legalized, it's much more standardized in terms of, for example, if you're getting dry cannabis or getting any sort of capsules. So there would be some sort of standardization in terms of, and being able to sort of tailor that amount. For example, if dry cannabis, it could be a certain percentage, and there'll always be a certain percentage. There'll always be the same certain percentage for that particular type of dried cannabis. So there could be opportunities for them to tailor and try to find that balance of how much dosing would be replacing how much alcohol during those weekly sort of check-ins with the clinicians.
Hi, Bernie, Corolla here. Can you hear me?
Yeah.
I can. It sounds like you're in the room with me, Corolla.
Okay, good. I'm just wondering if any of your studies are looking at mental health disorders along with the use of cannabis.
Yeah, that's a really good question, Corolla, because of course, one of the contraindications was if someone had also, severe mental health problems, particularly schizophrenia,
Right.
which could be exacerbated by cannabis. And so we would also in the protocol have assessment that would be part of the clinician role as well, in terms of people's previous history. And that's pretty well laid out in the literature around that assessment. And the other contraindication would be someone who has like a co-occurring respiratory issue, lung problems, would also be a contraindication. And we can send you more specifics on that in terms of assessment. So I think for us, we would build that into the protocols to determine how that would affect someone's eligibility for the program. Is Corolla, am I answering the question, or did you have something else in mind?
And no, you are answering it because, but I guess we're sort of between the devil and the deep blue sea here, because we have a lot of people addicted to crystal meth and opioids that we're also looking at using controlled cannabis for them.
Mm-hmm.
And a lot of them do have schizophrenia, but the outcome of them using the other drugs is much higher in their behaviors than it is in their marijuana. And I know that schizophrenia and marijuana are not that compatible, but I'm just wondering if there's a level that we can actually use it for them, because they're the ones that tend to go to the crystal meth and the
Right.
opiates.
Yeah, it's a great question, Corolla, around the clinical assessment of individuals and, kind of the harm benefits of
Right.
individuals. And I'm not sure what your clinicians are doing right now, or if you have a clinician because that would be a very important role to assess with them what their current usage is and the harms or benefits of substituting cannabis, and the right of the clients to make those decisions. Because I think we need to recognize that individuals who are participants in the programs are making decisions for themselves, and the right to make decisions about the use of cannabis, as long as the clinicians are providing, I think from our point as kind of healthcare providers and clinicians, if we're providing the information, clients have the right to make the decisions about their usage. Does that?
Yes.
So it's the importance of that individual clinical assessment, the client having information and their right to choose, which is something that probably should happen with all clients, because even in terms of being on MAP, advising clients around the potential long-term chronic harms is really important, because we know sustained consumption of alcohol has huge harms, and it may be better for them to move to cannabis, and same situation with other types of substances, as you mentioned, like crystal meth, for example.
Okay, thanks.
Oh, hi, Bernie. This is Jen Colomb. I was wondering if I could ask a question.
Ask away, Jen.
Oh, okay, yeah. Yeah, and I just want to let you know I'm here with Laura Fowler. I'm just orientating her to the AMCS role. So she's going to be involved in future rolling out of the managed alcohol program. But yeah, one of the questions, sorry, I kind of missed the beginning. And in terms of the study, where was it located? And are you looking at this program as being strictly in the community? Has there been any talk of it possibly being out of like a hospital, or would it be mostly sort of like community centers and like maybe some of the housing in the community?
Yeah, good question. So Jen, the research was done with 6 community managed alcohol programs. So it's people across, and it was done across Canada. So it was programs that are already existing,
Okay.
like something like 22 programs, and we collaborated with 6 of them to gain the information. I think your question is really important because we've got a new and emerging and kind of shifting environment around managed alcohol programs in hospitals, and when people are coming into acute care. And I think, you know, there's the obvious situation where someone comes in to hospital where they've been on a MAP or they've been on cannabis substitution that really pushes the question about hospital protocols. But there's also the situation, as I know, Jen, you and Island Health are looking at initiating MAP in hospital to increase people's you know, ability to stay and complete their treatment. So it does raise the question of the role of cannabis substitution as well. And I think, you know, I'm not aware, but maybe others are on the call, whether there's any inpatient, in-hospital examples of cannabis substitution for this particular population, because where my mind immediately goes is that, you know, people, if they're on medical cannabis, might be should be able to continue unless for some reason it's contraindicated.
I understand currently people who are on medical cannabis aren't receiving it in a hospital. I know there's been discussions about possibly changing that in the future, but currently I don't think that's where it is. So yeah.
Right. So it's thinking about, you know, I think, Jen, the important question might be to be thinking about it this now, remembering that at this time we haven't tested this in this population. That's what we're proposing to do. But you know, I think given some of the evidence, it would be maybe important to consider. We haven't thought about this in the protocol and the research, whether we should be including in-hospital sites. Sorry, I'm going to into my researcher brain there for a minute.
No worries. That's and I mean, in terms of the evaluation, because I'm wondering if we had talked about evaluation for the managed alcohol in protocol in the hospital. I wonder if the evaluation would be similar.
Yeah, the protocol would probably be very similar. I mean, obviously some differences in settings. So the protocol could be quite useful for the research of evaluating in hospital programs as well. Good point.
Oh, okay, thank you.
I know it's approximately 10 to 10 or 10 to somewhere, something, some hour, wherever you are. And I'm just wondering, we probably have time for one last question. And then we have a question to pose to you.
Hi, Bernie. It's Monica. I'm with the Ministry of Health in Victoria.
Hi, Monica.
And I was just wondering, forgive me if I missed it earlier, about the breakdown of the male to female and young to older in the study, and if you found any interesting differences there.
Good question, Monica. Clifton, can you recall, I'm guessing, I can't quite remember, it's on the, I don't think it's on the slide, but the proportion of males to female, Clifton?
I don't have that in front of me, but it would be more males than females that we had in this population. And we didn't look at any sort of differences in terms of gender at this point, I believe.
Yeah.
I was thinking about the age because of the long-term success of this. So if you have somebody who has an AUD and they're a young man, say in his 30s, perhaps he gets, is managed to, through treatment, to get better and drink a lot less. Would he continue with cannabis for the rest of his life? Like, what is the long-term plan for something like this?
It's a good question, Monica, and I probably just need to preface it by saying in the average age in the managed alcohol programs, if I recall correctly, is kind of 40, mid 40s. Clifton can correct me if I've forgotten or if he's got it at his fingertips. And they're mostly people that have very, very, very long histories of drinking. So severe alcohol use combined with homelessness. So I wouldn't say there are no 30-year-olds, but if they are a 30-year-old, they still probably have a 20-year drinking history, 10, 15 to 20-year heavy drinking history. So I think your question is a good one. As MAP programs shift to think about what's the future for people in the MAP. And so, if someone, I think what you're talking about is a model where someone really reduces their alcohol and then is on cannabis, and then it would shift into a conversation of what's the long-term impacts of someone being on cannabis, which might be less than alcohol, but is still got harms associated with it, and making continued informed client decisions about continuing on cannabis. Is that better than returning to heavy use of alcohol at various points? Or then, and I kind of like where your question is going, because if we truly are doing a harm reduction approach, the conversations that we're having along the way where clients can make decisions about use of alcohol, use of other drugs, use of cannabis, and abstinence, or tapering on other drugs as per their choices and guidelines. And my experience, and I know I've heard this from EDGE and other groups many times, it isn't that they don't want to have periods of abstinence. We even encourage that in managed alcohol programs. It's that they sometimes don't have the opportunities to either make those choices or access the resources that would support them.
Thank you.
Can I just add to that?
Go ahead. Yeah, please.
When we were sitting with them, and Josh, you can help me here with that gal, Rachel Orr, she was saying that people that get on managed marijuana, that the marijuana starts to address the issues that are going on in your body and in your mind. And it almost becomes a natural progression where they start to reduce their use of cannabis because the plant is doing its job and connecting with those receptors that need help, and that you could eventually see possibly somebody actually becoming using CBD oil. So, I mean, there's amazing things out there around what this plant can do for people.
This is Brittany. I would echo what Carola is saying, and I think that what Bernie said is also very true. In Vancouver, there's lots of people who are on managed alcohol programs or who are chronic alcohol users who want to have periods of abstinence or reducing their drinking, and quite often are not able to access the services they want in the timely period that they would need. So 2 to 3 weeks to get into a withdrawal or detox. Any treatment centers are usually full. They're going back to their SROs. So I think there's like a bigger picture here where cannabis and managed alcohol substitution are both great programs, but we have to start thinking about how they can be tailored to the person to move on to the other parts of their lives that they would want to move on to. So for a young person, if they wanted to move into their own housing, how would they have a cannabis substitution in there? How would they have a managed alcohol? How do they access therapy and other resources in that time? For older folks, like how does this look into long-term care or palliative care? So I think that MAPS right now are changing, and we have to start looking at the healthcare system and how that would change with that person and as they move into new phases of their own life.
Thanks, Brittany. That was a really helpful summary, I think. I just want to thank people for being on the call today and for the discussion and questions. Our question for you before we close is if you would like a specific webinar on or roundtable on opportunities to discuss and share protocols for programs like MAP around planning and responding to COVID-19. I think the plan is that Brittany is going to post that question on the listserv and see if people want that. I've been involved in quite a lot of research around homeless and pandemic planning previously. I know many on phone have experiences. So just any indication if you want us to do that, because we do have a platform that we can do it in a safe virtual way and support organizations as we respond to this public health crisis.
Thank you for this presentation, Bernie and Clifton. It was really good.
Good. Thanks, Monica.
Yes, and thank you from down here in California.
Hey, hi, Shannon.
Hi, love listening to y'all. And I posted up a quick comment, no anything to answer, but basically types of vaporizers without oil that can be smoked inside and don't produce smoke. So it could be something that could be dosed immediately on site without having to go outside in the cold, but produces the faster effects than, say, an edible would. So, but they're expensive, but maybe something could be done less.
Well, that's an example of where equipment could be purchased through the research program, for example. Yeah. Like that would be a good, if people were up for that. Thanks everybody for your comments, and watch for Brittany's listserv questions, and if we can support you in any way through sharing of information, supporting sharing of information and resources, please let us know. I think Josh may have left because he's teaching a class online at 10 o'clock or 11 o'clock his time. Take care, everybody. And it was great to have this opportunity to talk and share with you. Brittany, any words before we go?
No, I think that was great. It was a great presentation. We have one more webinar coming up in the end of April. It's another MAP profile on Grand Manor, which is in Edmonton, I believe. So that will be very exciting. So I'll send that update soon.
Great. Thanks, Brittany. Thanks, everybody. Take care. All the best.
Thanks, everyone.
Bye.
Bye. Thank you.